Why don't we start with that? What I really want us to be able to achieve is, I know we have a mix of experience. Some of you are very experienced and have been seeing patients for years, and I hope this is just simply a revision, maybe a go, oh yes, I forgot about that technique or something like that. And for some of you that'll be, or it's just a pleasant way to spend 6 hours with friends, and and it's not too expensive. So there's that. And then for others of you, you may not have touched a pregnant patient yet. Some of the students here, and it's lovely to have you here. And I really hope that this is pitched at all levels, because I'm not really a very complicated osteopath. The way I see osteopathy is it's a bit unsophisticated, probably a bit. It's unsophisticated really, in the sense that I really take the view, if something doesn't move properly and physiologically exposed to, I just need to find a way to make it move, and then stuff will improve, health follows. And that's really about it. And so I've spent the last 26 years trying to find quick ways of finding where stuff doesn't work in the body, and then fixing it and hoping there's an improvement afterwards. I don't do much soft tissue because I'm inherently lazy and I want to preserve my hands, and I'm not convinced that it really works. Other than the fact it feels very nice, don't get me wrong, it's great. I love having soft tissue done to me. I'm just not very good at giving that to people because I don't see an enormous benefit in it. But I think that when unless we fix the underlying joint dysfunction. So I suppose that's now. I could be quite broad with joint dysfunction, from straightforward somatic dysfunction, if we're allowed to even say that now, I'll say it, or osteopathic lesion, as it was when I was a student. I've recently done the qualification to animal osteopathy, and I was probably the oldest on the course, and most of them were new graduates, and we had some from other universities who'd never heard the term somatic dysfunction, let alone not know what it was. They'd just not even used it. And so I was curious as to sort of how they would then come up with perfectly competent, very, very bright, really, ran circles around me in terms of the ability to write essays, high academic essays, all that sort of thing. It was an absolute nightmare for me, but they were brilliant at it. But there just wasn't this, well, how do you decide what to do? And so for me, and actually, I'm not alone in this, there's quite a recent book produced by the American Academy of Osteopathy, or the American College of Osteopathic Family Physicians, and it's called Somatic Dysfunction in Osteopathic Family Medicine. So this is written by quite highbrow, doctors, these are proper pucker doctors, they've got real doctorates, and they've gone to a lot of trouble to define terms, and for whatever reason in Europe, we choose not to use this method of nomenclature, and it really makes it would be so simple. Every college in the US, when you graduate as an osteopath, they all have a common language. So, they will talk about T4, FRS, right? Everybody in the room knows what you're talking about. Everyone knows. Here, a few might know what you're talking about in the UK, but most are kind of like, T4, I think I know where that is. And then, in terms of, whether it's restricted, that doesn't exist anyway. It's just tell the patient they'll feel better, depending on, sorry, I digress. So, doesn't matter, crack them anywhere, it'll feel better anyway, because it's all just psychological. I don't believe that, obviously. So, somatic dysfunction can take the form of joint dysfunction, but it can also be within the organs, it can also be within the cranial system. So I do think that and you can use direct and indirect techniques, and they all work. There's absolutely no question. They all, in the hands of skilled individuals, they will make a difference. So I'm not at all prescriptive about the techniques that you use, and I just think we need to just be prepared to correct dysfunction. So I've spent a lot of time working with women in pregnancy. I was really lucky to study with Renzo when I was a student, and then I did some postgraduate stuff with him, and then I did the MIH course, and I teach for them now as well. But nothing I do is complicated. So what do I want you to be able to do on Monday as a result of being here? I want you'll have a clear idea of how to assess in general terms a patient who's pregnant osteopathically, and that you will then have sort of a strategy as to what you're trying to achieve and hopefully where you might intervene. But, I do have another hat, and this is what I'm going to be doing later today. I'm going to go into a demo for some horse owners, actually, but I just thought I'd put this in here because it's a cool video. So just right at the end, you can't really get the sound. So it's right at the end, we just get this. So I do believe in correcting somatic dysfunction. You see, there is this thing called horse massage, really hard work. It takes about an hour and a half, whereas I treat horses, it takes about 20 minutes. And most of that is assessment, and then just the odd adjustment. And you get extraordinary changes. Now, I could show you the video after to show how calm the horse was afterwards. But before, it was unbelievably uncomfortable. He'd go to touch at the base of the skull and it was pulling away, didn't like it, it was all high energy, do a little adjustment, and suddenly the whole horse calms completely. And what I love, the reason I showed that is that when you correct somatic dysfunction, changes happen, whether you're in a human or whether you're a baby, whether you're a pregnant mother, whether you're elderly, or whether you're an animal. If you correct the underlying somatic dysfunction, then you will make a difference to the health. And that's fundamentally all osteopathy is. It's about, and then obviously we've got all of the overlays of being safe. First of all, scanning for red flags and so on. So I'm going to start with that first of all, just because these are the sort of safety things that you must never forget. If you have a pregnant patient in front of you, you just need to ask or be aware of these 4 things. And honestly, you won't. I put them as the 4 Bs. I don't know. I'm sure I cribbed these straight from a book. But you must monitor blood pressure in every appointment. You must ask about baby movement, ask if there's been any bleeding, and ask if there's been excessive breathlessness. Now, obviously, women who are pregnant get more short of breath, and particularly it's one of the reasons they can't lie supine, is because pressure on the diaphragm makes it more difficult. But it can just be as simple as, let me just check your blood pressure while we're chatting, so how have things been? Yeah, baby been moving as normal? Noticed any bleeding at all? Excellent, and have you noticed any sort of particular shortness of breath or any changes in that recently? And that's all just past the interview. It's very quick, very low key. Nothing you need to make a drama about. But it's just really important that we do that. So I'll give these videos to you, but the main reason for blood pressure is we're checking for preeclampsia and eclampsia. These are potentially fatal for the mother and for the baby, and the only cure is delivery of the baby. So you do need to pick up if blood pressure is more than 140/90. It is an emergency and needs to be dealt with that day. Okay, and the mother needs to be monitored. So, having said I'm not prescriptive, this is one of the only things you need to be prescriptive about. You need to check every time, particularly now in COVID times, because women are not seeing health professionals nearly so much. They don't see their GP or their midwives nearly as often as they used to, but they can see us, and so we can at least check this more frequently. So it's really important that we do that. You could also consider just asking to bring in a sample, and you just get a dipsticks. They're very cheap and it's very easy to do, and you can look for protein, and it's very, very easy to do. So that's something quite simple that you can do as just part of your routine. Reduce baby movement. Always ask mum if there's been a change, if there've been any changes. That's the really thing. And if there's any reduction in reported movement, this should be referred to the midwife, and they should have a conversation that day. And they'll usually do an ultrasound or at least auscultate heartbeat and so on, just to make sure the baby's not in distress. So it is important we don't ignore that. But we don't ask that question before what stage? When does a woman start to be aware of baby movement? Because you ask a woman at 16 weeks, you're going to concern her because she won't be feeling baby movement. So at what stage does a woman generally, perhaps
19? 19?
It can be variable. Certainly
earlier in subsequent pregnancy.
It can be. It is earlier for something because women recognise the sensation, because they go, oh, that's baby movement. But for first, 20 weeks is about as early as they're going. 20, 21 weeks, somewhere thereabouts, they'll become a bit aware of movement. Okay, so they might at 18 or 19 weeks on a subsequent pregnancy become aware of movement earlier. So this is really something. Certainly from 22 weeks on, we start to, women are going to become much more aware of baby movement. So just be careful not to ask that too early, because then, oh, should I be feeling movement now? And of course, the one thing we're trying to avoid is creating more anxiety. Pregnancy is a potentially anxiety-generating condition, and we've medicalised it a great deal. But so long as we're doing these basic screens, pregnancy should be a fairly straightforward, nice physiological experience. And really, I see osteopathy as trying to support basic physiology and working toward a good birth. Okay, so vaginal bleeding, obviously, this is an immediate referral. I mean, you're not, as long as you ask about this, I mean, generally women are not going to ignore this symptom. You'd hope, but you know, just in case, it is a red flag. Also, yeah, low blood pressure is also another potential red flag. Fainting, fever or chills, or peritoneal signs. What do I mean by peritoneal signs?
Abdominal pain or?
Yeah, it can be abdominal, but also palpation. You know, it's going to cause peritonitis. You know, you're going to get tenderness, acute tenderness. And particularly early on, I mean, obviously, vaginal bleeding, the most common and most common is going to be miscarriage, and we need to talk about that actually. And ectopic pregnancy is the most dangerous. Ectopic pregnancy being, just so we're all clear. Yeah. So the fallopian tubes. So if this is my body is the uterus. Fallopian tubes, obviously fertilization occurs in the fallopian tubes generally, but we want it to migrate to the uterus and then it will implant there. But if that implantation starts in the fallopian tube, it's not a lot of space, and that's all going to get very painful and very dangerous very quickly. So these women are acutely unwell. Again, it's very unlikely they're going to be in your consulting room, but it might be something that you take on a phone call, because you do become a trusted professional. If you've seen people pre-pregnancy and they go, I've got this going on, should we just ring the topic, go to A&E? You know, it's just an immediate thing, okay? Vaginal being late pregnancy. Okay, so these are various, you don't need to know these, you just need to be aware of the fact that later pregnancy has various causes, which we're not going to go into. And I've put these in, I've copied a table here. So I will send this presentation to Claire and you'll get the slides later. Okay, so breathlessness, yeah, it is common, it is normal in fact, a normal state, but what we're talking about is if it's a sudden acute breathlessness with chest pain, we should remember that pulmonary embolus is a serious consideration and needs to be eliminated from the diagnosis, so we always refer immediately in those sort of cases. So what are the questions you should be asking? And again, you're going to get the slides, so you don't necessarily have to take notes on this, but all the normal questions you would ask around presenting complaints. So, you know, often when I was running the women's health clinic here, you know, you'd be like, oh, I've got a pregnancy case history, what do I ask? Well, look, most of these patients are going to come in with low back pain, you know, so ask all your usual low back pain questions, you know, ask all those normal questions that you would. But then, you know, you just want a little bit more detail, you know, about previous pregnancies, previous deliveries, history of miscarriage, terminations, and you need to ask these very sensitively. I'm putting them up here and saying it all blasé, but there are ways in which you practice asking these questions so that we're careful about that. How those deliveries were, whether they were vaginal, whether they were C-section, whether there was tearing, whether there were forceps, von-2s, whether they were induced, all those kind of things. And again, these are all the things that you just ask if you're an interested person. So almost don't memorize the questions. Just think, okay, let's just have a conversation, remember it, and then you can summarize it more quickly. One of the best things that I was taught about taking a case history was, you know, establish control of the interview. And I know this is really basic, and I don't want to insult people, but one of the first things, and then just put your pen down, or, you know, put your screen down, put your iPad down for a second while you're filling in Clinico or whatever, and then just look at the patient. So tell me why you're here, tell me what's going on, and then listen, because they'll have a story to tell. And then as they're going through our own pregnancy, so tell me about your previous pregnancies. Have you been pregnant before? Okay, and how did that go? And so you hear the story, state it back to them. So yeah, so you had a vaginal delivery, and then you had a C-section. It must have been difficult. How was the recovery? And it's all very conversational. And then you go, okay, now I'm just going to write some of that down. And it creates a contact with the patient. It also will lodge in your brain in a way where you get the information rather than just trying to take every bit down as they say it. Now, I have to say, you know, honestly, students are actually really good at this when they would come and, because I have a very low boredom threshold, and I found it very difficult to sit in case histories while students were taking them, partly because it would take about 3 times as long as I would do in practice, and I would just sit there. It wasn't an insight, well, they weren't doing anything wrong, I just found it really difficult, and I would go and do something else. So I would rely completely on them. I might go in for a couple of minutes and listen and go, okay, it's fine, and then walk out and then wait for the student to come and tell me the story later. And I have to say, on the whole, they did a great job. And of course, the way we do it, the students do it here, is that they've also got other people observing. So I'd say, did they miss anything? And often they didn't, or there were one or two little details. So it's actually done very well on the whole, I have to say, by the current cohorts. That was my experience. So this is not a criticism, but I'm just trying to find a way of making that job easier for you. It's just be interested. It's important to ask about recovery from previous pregnancies and also about previous and how previous labours went, because often there'll be high levels of anxiety around that. And the role we have is that we can provide lots of reassurance. You know, we can be their fan club and say, look, everything's working well. I can't guarantee it'll go well, but you know, the odds are it's going to be better this time. So we can really be a cheerleader for our patients and actually be someone on their side and not be someone who pulls them down with all these worries and so on. So yeah, I think the rest of that. It is important that we find out about mental health history, just because of clinical depression, significant clinical depression. Why do we ask about that? Yeah, postpartum depression, and more seriously, but much more rarely, yeah, postpartum psychosis, which is it's probably one of the only times you ever suspect a patient of having that, where you can breach confidentiality and go against the patient's wishes and make a report to their GP immediately and say, because what's the risk factor with postpartum psychosis?
They don't care for each other.
Well, there's care of the child, so the child's life and mother's life are usually at high risk. And so these women need to be sectioned, so they need to be placed in hospital, usually against their will. They will not be separated from their child. That's only on the very rarest of circumstances. They will generally try and keep the two together, but it's going to take a significant period of time while they're in hospital. Now, it's rare, it's 1 in 1,000 deliveries where there's postpartum psychosis. But previous history of depression, significant depression, where there's been medication, we need to be aware of that, so that we can be aware when we're talking to the patient and judging how things are going. Okay, good. So if we talk about normal pregnancy, I'm just going to try and do some of this sort of academic-y stuff first, and we'll get into more of the practical. We'll try and just get this out of the way, because if we do this after lunch, we'll all just be falling asleep. So, okay, so yeah. All fairly straightforward. We measure pregnancy, obviously it's 38 weeks, but we measure from last menstrual period, so that adds 2 weeks on generally, so that's 40 weeks and 3 trimesters. Yeah, this comes to the question of, you know, there is just normally, as a result of being pregnant, there's a high risk of miscarriage. And so this brings us to the question of, you know, do we treat, when do we start treating or not? And it depends on how risk averse you are as an osteopath, because there isn't a fixed answer to this. So there are many osteopaths who simply will not touch a patient in the first 12 weeks. They just don't do it. There's absolutely no clinical reason for that. It is purely a precautionary measure. There is nothing that we do as an osteopath that would cause a miscarriage. It just simply will not happen. It's just not going to be. It's entirely possible that someone could have a miscarriage within hours of a treatment, but the two are not linked. It just isn't. It isn't the case. If you were to turn it the other way round, you know, there are a lot of women who have terminations, and that's not a pleasant experience. It's all difficult. And you imagine, well, if I could just go to my osteopath and have him treat me, and you know, that would end the pregnancy rather than me having to see someone else. That would be, you know, a great way out. If you could just do a quick side roll on me, and that would, you know, that would make things all finished. Then that would be great. We would obviously be had up by the ASA if we were to suggest, you know, osteopathy causes termination. You know, if we would look at it in that point of view, there just simply is no evidence to bear that out. And so when we look at it on the flip side, is there any evidence to suggest that we cause miscarriage? None whatsoever. There just is none. There is no evidence to suggest that what we do is going to cause miscarriage. So there isn't a justifiable reason, really. It is purely precautionary, and it's simply to help you avoid having to have that conversation. And if you're not ready to have that conversation with a patient, then don't treat them. And actually, I mean, I will talk to a patient much as I'm talking to you now. I'll just say, look, there is nothing that we do which will cause an issue, but you could still have a miscarriage. You could have a miscarriage very soon after a treatment. And there will be times where you will question, should I have gone to the osteopath? But then, you know, you will also ask, if it happened after you went shopping in Tesco's, you will ask yourself, should I have gone shopping that day? Should I have just stayed in bed that day? Should I have avoided having sex that day? Should I have avoided whatever it is that they've done? They will question that, and they think it's led to. So you have to assess the patient's own view of the risk and really be sure with them. Obviously, if someone's in a lot of pain, one could argue that there's a higher risk of not treating because you're leaving the person in stress, in pain. That's putting more stress on the pregnancy than not treating. So it is a balance. So I can't give you a precise answer. I can tell you what I do, which I will treat someone at all stages of pregnancy, but I have that conversation with them, and I say you just have to be prepared. And if you'd rather I didn't touch you, that's absolutely fine. We'll just chat, and then I'll send you on your way, and then come back and see me at 12 or 16 weeks, whatever you choose. Okay, so that's how I handle that. How you do it is entirely up to you. So we've got these two terms you'll sometimes see as a P and G. G is a woman who's pregnant. Para is a woman who's actually given birth. So you might have G3, P2, meaning they've had 3 pregnancies and they've given birth twice. Sometimes you'll see that in some notes and so on. Particularly if you get to see the delivery notes afterwards. They'll sometimes have that as part of the history. Okay, yeah, so these are relative contraindications. Premature contractions. Again, there is an argument to suggest that we could treat to try and calm down. You're not going to use side rolls or other things during while the woman's having premature contractions. And vaginal bleeding of unknown cause. For me, again, I would perhaps go further. Now, I pinched a lot of these slides from Claudia. Claudia and I taught this course together undergraduate, so a lot of these are hers. And I would say there are not many circumstances I can think of where I would treat a woman who's got vaginal bleeding. And if you do that, and that's really true of all patients, really, we don't force anything in osteopathy. The way, it's all about listening to the body and the body's responses to your input. And if you listen to that and you'll sense when the body likes something and when it doesn't, that's the biggest guide, really, for being safe, I think. Okay, so first trimester. Lots of adaptation, but it's not very visual adaptation. We don't see much change visually. There's this high level of estrogen, which supports development of the uterus, enhances breast development. We see an increase in progesterone, which relaxes the uterus and helps tissues to stretch and accommodate. Half of women get this morning sickness, which can go anything up to 16 weeks and can go longer than that in some, and obviously can necessitate stays in hospital for some where they need to be hydrated because they really can't keep anything down. We'll talk about this pulling or stretching of the ligaments. We will look at how the various ligaments of the uterus and how they become under stretch or stress, and particularly if there's been previous surgery, abdominal surgery, appendix, or laparoscopies. All of those can create some kind of scarring, and that all then has to stretch during the first trimester. Interestingly, we think of women in pregnancy as having this massive increased lordosis, kyphosis, and so on, and that certainly is true later on in pregnancy. But in early pregnancy, you get the opposite. You actually get a flattening of the curves because you've got this, the uterus is not very big, so there's a slight increase in pressure within the abdomen that flattens the lumbar curves rather than increases. So in these early stages, we get this slight change of orientation. This can put more stress on the pelvic floor because the bladder becomes more vertical, so there's more vertical pressure coming down on the bladder, and it's being supported by the pelvic floor at early stages. So there are changes to the broad ligament, and that pushes up into the small intestine. So I think there's a picture. Yes, okay, so it's from Caroline Stone's book. I'll go to the... Am I in shot if I'm on this one? Okay. So, yeah, so we get this loss of curve, so we get slight elongation, flattening of the lordosis, and this posterior rotation of the pelvis, slight contraction of rectus abdominis, and the uterus goes from a hen's egg size at 7 weeks to a grapefruit at 12 weeks. So there's going to be quite a stretch on the anterior hip and infrapubic muscles. So you're going to create tension through the hip flexors and so on. Okay. So it's quite important just to remember that we picture a pregnant woman as kind of this, but early on it's not. And so there are changes. So there's going to be discomfort. So this is in these first 12 weeks. So what might we want to work on? If you were looking at this, what is your osteopathic instinct gut as you look at that now? You think, what would I want to try and do as a strategy? Any ideas? Come on, you've got a room full of very clever people.
What's the presentation though?
Yeah, you might think about psoas muscle. Yeah.
Back pain,
Well, I don't. They might have back pain. Yes, they might. Yes, good. So we have psoas, diaphragm.
Anything that relates to the pelvis?
Yeah. So all of the so hip flexors, the hips themselves. We are going to talk about the hips. Hips are really important. We talk a lot about sacroiliacs. We talk about the pubis, and we don't often talk about the hips themselves. And the hips themselves are enormously important in terms of how they function and how they allow adaptation to take place. So we're going to look at a few very simple hip techniques as to how we can, because the hip really is important, and we're going to talk about obturator as well. So, because all of those things are important to sort of pelvic circulation, congestion, and so on. Okay, good. Anything else Okay. So, end of the first trimester. The abdominal viscera, they're moving up as a column. So bear in mind, the viscera can't be compressed because they're fluid. We can't compress fluid. Obviously steam engines and others work on this. Anything that, or hydraulic systems work on this principle that fluids don't compress, and the abdomen is the same. So the only thing that can happen is the abdominal wall has to distend, has to stretch in order to accommodate change in abdominal pressure. So there's going to be build up on the pelvic floor, build up on the diaphragm, while this column of organs are being gently pushed up. Because at this stage the abdominals are not giving a great deal, so you're going to see change into the diaphragm, into the pelvic floor. So those are going to come under more stress. You're also going to get strain at the thoracolumbar junction. And of course, we've all been treating people through COVID and so on, and we've all seen people sitting like this, and everyone's really tight through their thoracolumbar junction. So we need to get good at dealing with the thoracolumbar junction, and we'll talk about that as well. There's, in some ways it's going to straighten during this early pregnancy, and then it's going to come under massive strain once the uterus starts to grow. And interestingly, we're going to see changes in the thoracic spine because, as we see, the majority of change in breast tissue takes place in the first part of pregnancy, first half of pregnancy. So see increase in breast size, which is going to create more tension potentially through the thoracics. That's where I do advise women to try and, if it's really affecting, get bra fitting. It's more expensive, but it's really important because it's going to make a huge difference to their level of comfort. So we've talked about so far pelvic techniques, the idea we want to strategize at working at the pelvis and the DL, but then thinking about this, we also perhaps need to get good at CD techniques, thoracic techniques, that we can improve that function, and cervical. So, frankly, we probably need to be good at it all, don't we, really? Okay, I just love this picture, one of Renzo's pictures, that you can see eventually, baby takes up an awful lot of space and stuff has to get out of its way. Everything moves out of its way, and we'll look at how the body adapts to that and the changes that happen as a result of that. So as a result of this growth, where we remember that the uterus starts off at this hen's egg shape, hen's egg size, up to the point where it's taking up the entire abdomen. There's going to be these huge changes in pressure on the hips, on the pubis, on the lumbar spine, but all of these organs are being shoved out of the way as well, and so they're all stretched on their mesenteries. It's going to alter circulation. So we need to think about how, and some of the other ligaments that pull on that as well. So we will come up with strategies as to how we can manage this and how we can make it happen. Now, thankfully, nature does most of that for us, but because we're in a society where we're less active than we were, the body struggles. If the fitness is good amongst patients, if you treat patients who are already very physically fit and very active, it's amazing. They have a great pregnancy most of the time, not always. Obviously, there are exceptions to that rule. And then you get others who start off who are a little overweight, out of shape to start with, they're the ones who struggle. They get swollen ankles and they kind of just, struggle to do anything. It's all just a bit of an effort. And we need to be able to support both and find ways of doing that. And sometimes we're not going to fix everything. All we're going to do is just be able to manage, help support the physiology. Okay, yes, that was the point. I knew there was a reason why I showed. So, imagining all this stretch and so on that's going on, how does that happen? How does it happen? If you remember the broad ligament, does anyone have probably no one's brought a blanket with them or anything, or a sheet or anything? Ah, marvellous, okay. All right. So, thank you. Is that alright if I model this slightly? So, okay. So imagine this is broader. So I want to imagine, first of all, that the ligaments all get lots of individual names, and it's not really very helpful when we look around the pelvis and bladder and rectum and so on. You just need to think of them as, essentially we've got, I'm not a good drawer, so imagine that's the diaphragm, this is the spine, this is the abdomen, and then we've got pelvic floor, effectively. So this is peritoneum, which surrounds this. You've got two layers of it, and effectively it lies. You've got the bladder will sit here. You've got the uterus sits in the middle here, and you've got the rectum at the back here. And effectively, what the peritoneum does is come down and create folds over the top of that. And what we do is we name all these individual structures, and it doesn't give you this nice global view of what's actually really going on. So we've got the broad ligament, which is probably not entirely correct because it's split into different names and so on, which sits over the top of the uterus. And then we've got this vesico-uterine pouch, and we've got pouch of Douglas back here, which is the recto-uterine pouch at the back. But it's all just peritoneum. So that's all it is. So we've got to think about, in the non-pregnant state. If you imagine again, my body is, I'm the uterus, and then my arms are the fallopian tubes out the side here. So if we just take this, so fallopian tubes, you've got this peritoneum folding over the top, different layers of it. And that creates effectively 4 layers there around. So because you've got 2 layers at the front, 2 layers at the back. And so all of that's got to stretch. You imagine this structure that sits over the top. Peritoneum is going to have to, as I start off small and as I grow up, that peritoneum is going to come under huge tension. It's almost like a parachute over the top. So all of that's got to adapt. And we've got to think about that. So just think about it as folds of peritoneum rather than other structures. But when I talk about the broad ligament, I'm just talking really about this draped structure initially that's under low tension in the non-pregnant state, but becomes under much greater tension as everything grows. But then there are other things which have to change. So if we look here, we've got, so just to orientate, this here we've got the lateral wall of the uterus here, okay, and then we've got these folds of peritoneum over the fallopian tube, and then we've got the ovary at the end here. But what you can see here is that there are little folds within this. Can you see these little folds? Okay, this is produced by Kamina, and this is what allows the structure during a pregnancy. As you can see here, you've got these folds on the left-hand, the far left-hand side, and then as the uterus grows, then it all unfolds and comes under tension. But if you've got little adhesions between here and here, it's going to be harder for that to happen, and that's going to be painful. Okay, and it's going to be uncomfortable. It will give, because peritoneum is of that sort of structure. It will eventually give. The force of the uterus will overcome that. It's not going to get held back by it, because it's, the uterus is big, thick, muscular structure. You've got the baby, it's all under pressure, you've got amniotic fluid, so it will overcome that. But it's going to be uncomfortable, and it can be quite sharp. And remember, the peritoneum, particularly the outer layer of peritoneum, has a somatic nerve supply. What do I mean by that? It's dermatomal, so it's very specific, and you can localize it very quickly. Whereas a deeper layer of peritoneum has an autonomic supply, sensory supply, so that doesn't go to the homunculus of the brain, so you just get this general sort of rumbling pain. So one of the ways, for instance, we talk about this idea of appendicitis. When someone gets appendicitis to start with, where does their pain start? It doesn't start down here. It starts usually often centrally and then migrates over the few hours. So what's the mechanism of it going from here to here? we know why?
Is it where it comes from in the spine autonomically? Or?
It is to do with the autonomic, but it's how it's perceived in the brain. So you know we all have this homunculus that allows us to know where everything is. So I can close my eyes, I can touch my nose, I can touch my chin, I can touch my elbow, and I can do that with all, and I can feel that. You can touch me anywhere and I can tell you exactly where it is on my body, because that's the homunculus. I've got a very clear map. For the organs, we don't have a homunculus. So when the organs hurt, we just get a general autonomic response. So if we have infection, we often feel, we get palpitations, we feel sweaty, we feel nauseous, we get a pallor. So these are all autonomic responses because you're getting autonomic sensory information come in. So when someone gets appendicitis, they feel like crap, they feel nauseous, they'll be sick, they'll have a general sort of pain because there's nothing specific. Once that the inflammation becomes such, and you remember the appendix is down here, so once the appendix gets inflamed enough that the superficial layer of peritoneum becomes inflamed, then suddenly the pain goes down to here and it's localized. So, bearing in mind then that peritoneum, we have these two layers of it, during pregnancy, often we can get this very sharp pain. And the reason is because it's superficial layers of peritoneum that are coming under stretch. And so that's why you get this localized pain. And that's how you can differentiate it, it's stretching pain, as opposed to something more serious with abdominal pain. If someone comes into you and says, oh, you know, in the last hour or in the last, you know, today I woke up and I've had this really sharp pain here. You know, you're always in your head, as a student particularly, you're thinking, oh my gosh, is this appendicitis? Should I be referring? Of course you refer those cases, but you can say 9 times out of 10, that's not going to be anything serious because it started off here, it started off superficially, and they haven't got all of the autonomic responses going with it, the pallor and so on. And if you want to think about that again, think about cardiac patients. They don't say, I've got heart pain, it'll be pain in the arm, it'll be pain in the jaw, it'll be sort of in the neck, and they look ill, they're breathless, they feel sick, they often vomit, they look pale, they sweat, you know, so all of those things that we think of with cardiac patients, it's the autonomic sensory system which is what they're giving off. I read a really interesting study years ago where apparently paediatric patients who've had open heart surgery, their brain is wired such that when they get rib pain, what we would classify as rib pain, you know, obviously, you know, when we see patients with chest pain, we always have to think about cardiac, but often because of the nature of the pain, it ends up being rib. But when children get that, if they've had heart issues before, when they perceive rib pain as heart pain, it's a different, because their nervous system was not hardwired that way. It was so early on in their life that their brain has wired that sensory system, so they perceive pain slightly differently. Apparently, I don't know how true that is personally, but why am I going on about this? I suppose it's just this idea of how we perceive pain and why we get these sharp pains. It's because it's a superficial layer of peritoneum, because of its innervation, is going to give these localized sharp pains. They're not going to cause the patient to feel nauseous or ill in the same way as an infection would. So it's very clever, this system, and we see the ovary will move as well. The ovary does move up, but the ovary does have various attachments to the lateral abdominal wall, to the uterus, but also to the peritoneum. So it will move. So we need to be able, there are ways in which we can treat that, make that all more comfortable. So during the second trimester, we see changes in posture, quite marked increase in lumbar lordosis. This creates this pull on the thoracolumbar. And again, think about the effect that's going to have in terms of innervation to the uterus. And we see varicose veins may occur. So why does that happen? Where do women tend to get varicosities? Again, in the legs, obviously, most commonly.
With rectal hemorrhoids.
Yeah, hemorrhoids. And they can get labial varicosities as well, which they often won't tell you or talk about. They can be incredibly painful, though, and so it's important to create an environment whereby people can feel comfortable sharing that, because there may be things we can do to improve that situation. Just very simple techniques of lifting and supporting the uterus. Teaching a partner how to do that can be incredibly helpful. Just getting a standing patient who's pregnant. Actually, I can't just demo camera. All right, you have to imagine, because otherwise we have to put all the PPE on. So imagine, okay, I'm pregnant and I'm just coming around from behind. You can teach a partner just to bring their hand just interlace just below the bump, and just lift, and have the patient have them lean back against their partner and just lift. And that in later pregnancy can be incredibly comforting. It takes pressure off the lower abdominal over the skin. It is really good for support, and just teach them to just gently rock. Not everybody's going to manage this, but you know, it can be really helpful, and it's a nice thing. Can help partners feel useful, and it's actually something that really can be quite beneficial in terms of releasing pressure from the pelvis. So venous congestion just simply happens because there's a change in compartmental pressure. The venous system is low; is a low pressure system. So anywhere where there's blocks, again at the pelvic floor or the hips, you know, anything distally to that is going to get backed up. It's very simple sort of physics. I don't want to insult you with that. So third trimester, we get this really, it starts to get more uncomfortable just because everything's coming under stretch and the baby's really big by now. And there is this interesting thing that you can have women who are incredibly fearful of labour through the pregnancy, but from 36 weeks on, they do start almost universally to get really uncomfortable and start to get fed up. And they kind of start saying, I want my body back. I want to, you know, and it's really interesting. It's nature's way of preparing women to expel, you know, have their body back. It's really interesting. You can see people who go from this state of total fear to one of being fed up and angry. And I say, this is great. This is really good news. It means you're ready for labour. You should feel really encouraged by this. You don't need to be afraid. You're going to be okay. And nature kicks in. And it's really extraordinary how this happens. So the discomfort is important in that sense. It's a real, and perhaps because of the amount of it affects sleep, perhaps a good preparation for those early months after the baby arrives. So there's a change in centre of gravity. So we need to manage the soma, the body, well. So that's diaphragm, psoas, sacrum, sacroiliacs, all of those things. And all of those things, if we manage those things, we improve the comfort of the mother, which ultimately is going to make things more comfortable for the baby as well. And we also, in the third trimester, really want to start thinking about birth mechanics, how we can influence that. So we're going to look a little at birth mechanics and the stresses that take place and why we then need to intervene in the way that we do. So these are the various blood tests which are done. I'm not going to spend time. If you really want a good source of information, it's not too expensive, this book. It's really, really good as a cribbing book. It's just called the Unofficial Guide to Obstetrics and Gynecology. It's incredibly helpful. You're welcome to look at it in a break and just see what you think. But I think it's a really good resource. It's very easy to read. It's very up to date. It's English in the sense that it tells us about the NHS, how that works, what tests are done and so on. All the investigations. It's really aimed at doctors, so it tells them everything that they would need to do, how they would do an amniocentesis, how they would do this, why they would do various different procedures, and it's all here. So if you then want to find out about these things, you can then read them here and go, oh, okay, that's why that's done. And it's explained in a way that for clinicians, which is what we are, you know, so it's really useful.
Michael, who's the author?
It's a mixture, Wood, Lati and Qureshi. But it's yeah, you can get it, certainly get it on Amazon. It's really excellent. Very nicely laid out. Lots of pictures, easy to read text. It's all the things that I like. Okay. Okay, so what actually happens in the UK in terms of screening and support for the students, in case you're not aware of this? So in theory we have regular visits to the midwife. That's still a bit patchy, not really happening so much. So there should be 2 ultrasound scans, 12 and 13 weeks, and so between 20 and 22 weeks. And they will do blood pressure checks, urine sticks, and there will be physical examination for looking at the tummy growth. So one of the things that they measure to see how, just in basic clinical examination, is another one that you can do. You can get a little tape measure, and you can measure from the top of the pubis to the top of the thumb. You can't do this until 20 weeks or beyond, really, so whether the uterus is big enough. You use the ulnar border of your hand, coming from the xiphoid, and you come down until you find the top of the uterus, and then you put the tape measure from the pubis and measure there, and basically you should get a centimetre growth for every week of pregnancy. up until about 36 weeks, and then the baby begins to drop down into the pelvis, and so you no longer see it growing. So up to 36 weeks, you should see 36 centimetres of growth. So that's, as a basic rule of thumb, if they notice a difference with that, then they will often then refer for ultrasound to see, is blood flow okay to the baby and so on. So that's a very simple thing. We can do that as well. You can check for the baby's lie as well, the position of the baby. So 2.5 stone. If they're going beyond 2.5 stone weight gain, they really start thinking about diets and so on, and really weight control.
If the patients are dematous, then
yeah, absolutely. Yes, I mean there can be pathological reasons for that, and they will check that. That will be because there will be there can be excessive polyhydramnios, so it's too much amniotic fluid. But generally that will be picked up, and one of the reasons that they weigh patients is to look and see if there is increased, yes, and they look and see whether they're diabetic, whether the baby, because if the mother's diabetic or pregnancy diabetes, they're going to get an increased baby size, which is going to make delivery more risky and so on. But it is important that we don't allow women to sort of believe the myth that you're eating for two and it's okay just to eat as much as you like and just give into cravings and not take any control, because it does create a risk for delivery and just for their general health as well, and the health of the baby afterwards. Yeah, we won't talk about a lot of these things, you can just look at those later. So treatment threatening prematurity. Yeah, basically all we can do is when women are at risk is that we can still treat them and we just think about how we can reduce the stress on their body. So it may be that they've been encouraged, that they're at risk of premature labour. By supporting their physiology, we can hopefully create optimal conditions whereby that doesn't happen. We can't guarantee it, but it's worth trying. And if it were my partner, that's what I'd want to happen, so that's what we would do. So always think about treating mechanical strains and particularly strains on the uterus and potentially the cervix, although we're not going to cover that. Those are internal techniques, so those are for another day. Okay, yeah, so in terms of conditions that will develop often, it doesn't have to happen just in the third trimester, but it's very common in third trimester. SPD, has anyone seen? Yeah, I mean, obviously those of you in practice will have seen lots of this. Students, you know what SPD is? You see anyone? Okay, so it's basically pubic pain, chronic pelvic pain, or pelvic girdle pain, PGP, I think is the more common, yes, is what we should be calling it. But SPD is one version of that. PGT, pelvic girdle, dysfunctional pelvic girdle pain can be the pubis, it can be sacroiliac pain, basically anything really from umbilicus down to sort of top of the thigh can qualify as that. But SPD is a very specific issue. I think we can have a lot of success with this. I've seen lots of patients with SPD over the years and got really good results with changing them just with really basic techniques. And that's really keeping the sacroiliacs mobile more often than not, and not actually doing a lot of treatment directly on the pubis, because the pubis is already more mobile than it should be, so we don't really want to be mobilizing it anymore. We just want to be immobilizing the sacroiliac. So as a strategy, I would say often what happens is that they're very tight to the thoracolumbar fascia. They get they're sort of got a very fixed lumbar lordosis, so more weight is going over the pubis already. So we want to be trying to improve flexibility through the lumbars, improve sacroiliac mechanics, so that's piriformis, psoas, and if we get those functioning better, often then the SPD will settle. I would say the earlier the intervention, the better. So as soon as they start to get symptoms. So this is one of the reasons why you need to ask about previous pregnancies, because it tends to get worse with subsequent pregnancies as they go on. So if a woman's had it in the first pregnancy, she will get it in a second pregnancy, and the chances are it'll be 4 to 8 weeks earlier than it was the last time. And in the most extreme cases, women will just be on crutches. They won't be able to walk at all. They'll be really struggling, but they'll only be able to get around on crutches. It's one of the few times where I think there can be some value in using a Sorolla belt to support. So for students, it's a sacroiliac belt. Sorolla are the best ones, as far as I've found. They're about 40 quid for patients there, and they sit below the bump, and it's really just above the trochanters, you will, and it really makes a significant difference. It can really help the patients. These are patients where we have to advise that they just don't do much. They can't really go out and walk as much as we would want them to. Ideally, we keep them active, but once they've got SPD, if they go out and walk too much, they are going to make their symptoms worse. So we really do have to discourage that. It really goes against the grain because it's not what we want, but they will only get worse if they walk excessively. So they have to do some exercise, but it's really very, they have to limit it. So yeah, again, it's all about trying to assess where is the most dysfunction and treat that and take the loading off the pubis. So low back pain, incredibly common, and again partly because of the shifting gravity. Thoracolumbar fascia is the structure which balances this change in amongst others. This change in center of gravity. There's often this mild pelvic instability, and often there'll be, this large breast will cause more upper thoracic pain and thoracolumbar fascia discomfort. So low back pain is really common, and we will talk about how we deal with that. Sorry, these are not showing up particularly well. They are on the back, but as I say, you'll see. Am I in shot this side? I can't remember. Is this side? Yeah. Is it this side or this side? It's this side. This side, yeah. Okay. Okay, so I think probably of the most importance here, obviously there's an increase in the cervicothoracic lordosis. This leads to a compression at the thoracic inlet. Why might that be a worry?
Circulation.
Yes, exactly right. So we're not just biomechanists as osteopaths, we are also very interested in the circulatory model. Remember, we've got the 5 models of osteopathy, the WHO have outlined, and we often just give lip service to the other ones, but in pregnancy and in women's health generally, the circulatory model is preeminent. And so one of the first things I'll get you to check is the thoracic inlet, first rib and all of this sort of fascial quality around the clavicles. And so if you're sitting back into that, all of the lymphatic system drains into this subclavian area. So if that's compressed, that mechanism is compromised, and that's going to have a distal effect elsewhere. So as soon as this is the final destination point, if that's blocked or compromised in function, then you're going to be more likely to have lymphedema elsewhere in the body. So that's really important. Obviously, with this strain on the abdominals, and so it's really common to see the rectus abdominis to separate during. It doesn't always, but in many women it will. You will see this natural separation. So the fascia which links the two halves of rectus abdominis separates, and then that will. So this is diastasis recti, and I'll show you how to assess this post. Pregnancy as well, because women worry about this a lot. It is a known cause of low back pain if it doesn't resolve. There is no magic way to make it go away, despite what Instagram tells you. I've yet to really find any convincing evidence of what we can. It will either get better or it won't, and if it doesn't, often surgery is useful. And essentially you palpate around the umbilicus and get the patient to lift their head. And if you can get more than one finger between the rectus abdominis, then that's more than they should have. Really, it's only in a year, it should be no more than a finger breadth. If you've got 2 or 3 or 4 finger breadths, then that's going to lead to. Bear in mind, because of the way the abdominal fascia works, everything inserts into rectus abdominis. Remember the obliques, everything. So once you separate rectus abdominis, there's no muscle support. Centrally. Now, for caesareans, they take advantage of that. Remember, they just cut the skin, cut the superficial fascia, deep fascia, then they separate the rectus abdominis rather than cutting muscle. So muscle's not cut during a caesarean section. They simply separate rectus abdominis, push the bladder out of the way. So women who think if I have a caesarean, I'm not going to have any bladder issues after. Not so sure about that, because they shove the bladder down, regardless of its attachments, out of the way, and then do a transverse cut or sometimes a longitudinal cut on the uterus in order to get the baby out. So so rectus abdominis is not separated. So they make use of that mechanism of separation during a cesarean. So the abdominal muscles should knit back together very well. So that's another really important thing. Sorry, I'm jumping around a bit, but in a lot of women you'll see with, we can talk about cesarean section scars, how to manage those. And I feel really, really, really passionately that we need to get women to be not afraid of these scars, because they're terrified they're going to split the scar because they're worried their muscle's been cut. And it obviously hasn't. The muscle's still just as strong as it ever was. So they're not going to separate it, but they're terrified they're going to. And you know, we can see, particularly in a women's health clinic, women who've had cesarean sections 30 years before, and they still have pain on their cesarean scar when you stretch it. You know, it's never been treated, they've never done anything. Say, has anyone talked to you about your scar? No, they just told me to leave it alone. And I get patients to start to palpate it right from day one, effectively. Just palpate through the dressing. Don't have to do anything with it, just palpate it. Just get a sense of where it is, don't be afraid of it. Once the dressing comes off, have a look at it. Start to touch it, touch on, gently move the skin overlying it. And I give patients who've had them 30, 40 years ago, I'll still get them to start to mobilise. And honestly, a month later, it's completely different. It changes, and their pain is reduced. It reduces stress on their low back, and so on. It's really important. But if you carry this psychological fear of this, you carry yourself differently, and it creates this big fear in your head as well. So education is a really massive role that we have to play as far as that goes, to remove fear around that. Any other thing we really want to talk about this? No? Okay. Obviously there's a lot of compression on the discs and so on, and the facets particularly of the lumbar spine, because we're getting this big arching back. So anything that's preventing those vertebrae from being able to extend comfortably. So these, in my language, would be called an FRS restriction. And what we mean by that is these vertebrae love flexion and they hate extension. So if you have people with an FRS restriction in the lumbar spine, I'll talk about how we assess that later and how we can do that in pregnancy, how we can look for it. It's very, very easy. And how you can then correct it. And 30 seconds, you can correct it in, well, a minute maybe. You can correct it and you'll see instant changes. And the level of comfort you can restore to the patient is extraordinary, just through a very simple, targeted application of technique. So, as I say, nothing I do is complicated. When you actually see it, it sounds like, oh, these are sounding like amazing things, and I'll show you. Go, oh, is that it? You know, is that all you're talking about? But honestly, if you just follow these simple steps of assess and then treat, I would try and get through as many of these as possible, and then we'll get on to practical, I promise. So, okay, so this really is just showing the changes that we see in the pelvis. Obviously the iliacs get pushed out with the weight of the baby, so that's going to create extra pressure on the pubis. So we really want the hips to be able to accommodate this movement. If you're seeing this flaring of the ilia, in order to be able to do that, yes, you've got to have mobility at the pubis, but you've also got to be able to have mobility at the hips. So if the hips have reduced mobility, then the ilia are not going to be able to rotate around that. So the hips are really key. So I'm making a big play for the hips today. So we're going to do a technique on the hips, not this one. I'm going to do another one. Okay. So again, this is just showing the changes that take place. What I want you to look at in this, see the change in the lungs and actually in the ribs as well. I think I've got a slide later which will show you. You'll see often that the lower thorax changes shape during pregnancy, and it never goes back. It remains that way. It changes. So these are permanent changes. These are not usually reversible. They sometimes will, but most cases you'll see this this change in the lower thoracics. And that's just, it also alters how the diaphragm will function. And so you can understand why breathing becomes a little, why women are breathless. So there's normal breathlessness for pregnancy, and then there's obviously the acute one associated with pain. But you can understand why, because of all the pressure that's going up on the abdomen, everything that's got to get squeezed into this space. So we can see here this layer of peritoneum over the top here, and here now it has to stretch enormously. So the changes that have taken place. It's incredible that the body can do this so well. Yeah, that's all fairly straightforward. I don't think there's anything. Yes.
Did you say permanent bone changes?
Yeah.
So the ribs
will remain flared pretty well. Most women who've had a baby, their lower thorax is a different shape after they've given birth. Unless you've got a long abdomen, in which case it accommodates it well. But certainly for women who are shorter and have a short abdomen, there'll often be a permanent change in the rib cage. If you're taller, then you've got more space and you can accommodate it. But certainly women who are shorter, it will be permanent. No, I mean, it's not always dramatic, but it is a change. Yeah, it does happen. Yeah. Just be sure that we understand what I'm talking about with increased sacral mutation. Just so we're clear. So imagine this is the anterior part of the sacrum, posterior part of the sacrum. Mutation is that movement. Counter mutation is that. I just want to be sure that we're all on the same pages. That's what I mean by that. So there's an increased sacral mutation. So we're going to do the Kathy technique or the frog technique. And we often think about that as being used for the psoas muscle, but it's also useful for a bilaterally mutated sacrum, which takes place late in pregnancy. You'll see this, and it creates this acute lumbosacral angle, and you want to try and decrease that. So the Kathy technique, or the frog leg technique, or frog technique, is really helpful. As well as working on psoas, it works to help counter-mutate the sacrum, and so decrease stress on the lower lumbus. We're going to talk about the coccyx as well. Really, really important that we understand how to assess the coccyx. So the thing I used to run into problems with the women's health clinic is that you've got this treatment of intimate areas, and you're supposed to get consent for every time you palpate. If you palpate the pubis, we do that on every patient in the women's health clinic. We not just get them to sign a separate form, just allowing us to be able to palpate their coccyx and palpate their pubis in every case. In all honesty, the only time I use consent forms are for internal work. It's the only ones we're obliged to. Otherwise, I just seek verbal consent and just put it in the notes, to be perfectly honest. But I know for the students, Carol will give you guidance on what the current policy is in terms of what we...
I think we're okay for cubics in the
That's good. Good.
As long as we've got...
Yeah, you've got the verbal consent and you've recorded it in the notes, but there was a push for a while to try and get signed consent.
You never get through it.
You never do it. You'd just be doing it for every single case because we wanted every single person being. So we just need to get comfortable at palpating the coccyx, assessing it. It's very, very, very easy to treat, but it is often we just need to get comfortable palpating it. It's really no different to any other structure, but sometimes because we don't, we become afraid of doing it, and so I just want us to be sure that we're not uncomfortable doing it. You can make real changes. Do I need to put in? Yeah, I don't need to talk about this much. That's all fairly clear. Oh yeah, so this is the respiratory changes. You can see how breathing is going to be different. The way the diaphragm is able to get leverage is going to be different because of the changes that are taking place in the flaring of the ribs there. Okay, now one of the other symptoms that women in pregnancy will tell you is that they have to pee more often. Yes, it happens all the time, and it never really goes away for the entire pregnancy. It just remains the whole time. So is it because there is increased, and sometimes it doesn't recover after either, and trampolines become a no-no, that's all that. It shouldn't be, actually. I feel really passionate that women after birth should be able to use a trampoline without fear. They really should. Why not? It's no man would put up with that. Was it Frank Willard said about... He said, he makes a comment, he said after 50, he said it's amazing that men are ever able to pee, and it's amazing that women are able to have any form of control of stopping the bladder from contracting, because obviously two slightly different. Men increasing prostate size, and for women, because they've lost the estrogen, pelvic floor tone changes. So, but there's hope, and osteopathy has a real input for all that. So the question is, why does this happen in the bladder? And it's not just because of pressure. It's always easy to think, well, there's increased pressure on the bladder. It's partly that, but actually, it's because the uterus is growing all the time, it's creating stretch. And remember, you've got the broad ligament, which is peritoneum. That peritoneum is attached to the bladder, and so it's pulling on the bladder, and so the stretch receptors are being activated much more. So it's not so much the physical pressure on the bladder which is changing, it's the fact that those stretch receptors are being fired all the time, because the bladder never gets to sit at a comfortable on a level like it normally would, because there's always change. So the bladder's always being stretched. So those stretch receptors are being triggered more often. So that's often the reason for urgency and increased frequency, is because of the stretch receptors firing off, not because there's increased pressure necessarily. It's interesting. I just thought that was fascinating. I didn't. Cloudy taught me that when I was. It's just interesting. Okay, so this is just looking at the various muscles that have influence, and really, and again, it's the role of pectineers, piriformis, obturator, gluteals, and the inguinal region, and all of the abdominal. I mean, it's all fairly self-explanatory, but it's just remembering all of these structures all have an ability to have an influence. And so we talked a little about thoracolumbar fascia. And really, it's just this junctional zone. It's deep. We can't. There is, this technique of picking up. It's actually superficial fascia. When we pick up the skin and we kind of do this little tug. If you've ever been in any of Renzo's classes, and he's shown you, he does this little thrust on the, and you can get these nice little. It's almost like popping. That plastic wrap with little bubbles in. Bubble wrap. Yeah, it's like doing that. It's really satisfying. It is very, very nice. But it doesn't address thoracolumbar fascia. We've always often taught it as actually working on it isn't. It's working on superficial fascia, and it's actually simply creating separation between superficial fascia and this deep fascia, which is thoracolumbar fascia. Thoracolumbar fascia is really tough. You can't pick it up. You can pick up skin and superficial fascia and some deep layers of fascia, but ultimately, and it will have an influence on thoracolumbar fascia, but you're not picking up thoracolumbar fascia. So we'll show you how you can. Stretch is probably the wrong word because it's such a strong structure. We can't really stretch it, but we may be able to influence it. Influence it neurologically. But it's going to carry force from gluteals up into that dorsi, so it's being transmitted. Obviously, rectus abdominis, not rectus, the obliques also take their attachment from the thoracolumbar fascia. So it's really important structure. So we really want everything around it to be functioning well. And obviously it's going to play a huge role in how we adapt to the forces of pregnancy. Okay, so we've got 15 minutes now. Let's just talk about these. So once we get, so that's sort of pregnancy, really fast. We've gone through it quickly, but I deliberately don't want to just spend all day. We could, it would just be too much. So that just gives us basic input. Now we want to think about labour, and during labour we see that the baby has to rotate. And we have to think about what influences those rotational factors during labour. So part of that is the morphology of the pelvis, the pelvic inlet. So that will influence the way the baby will turn. But then there's also muscular factors, the psoas, the diaphragm, piriformis obturator, the levator ani, and the uterus itself. So we're going to look at those, and because the reason I picked those is because those are all structures we can influence. So in theory, if we can get these muscles functioning well, then we can improve the potential for the baby to be able to turn during labour. Okay, because it's important the baby's able to do that. So we know because of the shape of the pelvic inlet, the baby's head has to go in on an oblique angle, either with the occiput anterior on one of the sides or the occiput posterior on one of the sides. But it can't enter, the head is too big to be able to go into the pelvis in an AP diameter. It simply won't do that. Levator ani. And you can see during normal times it is drawn up, and this is to hold everything in, to stop anything from coming out. But during labour, we see the pelvic floor will distend downwards inferiorly, creating almost like a steps for the head to engage this rotation. Okay, so this roll. So if the pelvic floor is not able to go from this to this due to scarring or hypertonicity, that is going to adversely affect. It's going to make labour longer. Now the fact is, because the uterus is so strong and the contractions are so strong, then ultimately the pelvic floor will be the bit that pays the price. It will be damaged. It will either be tearing or it will have to be cut in order to accommodate delivery. But any midwife will tell you if the pelvic floor is flexible and able to give, it makes delivery easier. And one of the roles of midwife is to try and prevent pelvic floor damage, because ultimately that's a very severe thing later. But it plays this role in rotation, in fetal rotation. So we can assess the pelvic floor, and there are ways we can do that in a non-invasive way, which we will cover as well today. So if you have a hypertonic pelvic floor, you can imagine it's going to affect the mobility of the ischial tuberosities. So they're going to be held closer together. That will alter gait. And that can lead to relative potential hypermobility in the sacroiliac joints. And that potentially could cause more SPD. So that cause lower lumbar or pelvic discomfort just because the pelvic floor is tight. So we should always assess the pelvic floor. Even if the patient isn't complaining of symptoms in the pelvic floor, we should always assess it, because if there's greater tension on one side over the other, then that could be leading to indirect low back pain, pelvic pain. Okay, so now we're looking at levator ani and piriformis. There's a really nice picture here. So we have piriformis here, and then we have coccygeus, iliococcygeus, and pubococcygeus, which are all really levator ani muscles. So those are the steps that the babies face. Now, imagine which bit of the baby's head comes in contact with piriformis here in the ideal labour.
Like the head, shoulder area.
Oh, yeah, because it can be music. Yeah, nose. It's going to be the face. Face is going to come in contact with piriformis, ultimately, because they come in on this oblique angle. So ideally, you want the occiput in an anterior position, usually on the left.
So at the end, you mean, yes. Okay.
So as the baby is coming down, their face is going to come in contact with piriformis. So if the piriformis is hypercontracted, you know, that's a lot of pressure can go through the facial structures, through the nose. Now, obviously, babies' heads do. Obviously, ideally, they're going to be flexing their head, so it's this bit which is going to be facing, but nevertheless, piriformis can have an influence. Piriformis is also part of this rotational, it influences rotational factors, okay? It's part of the cushioning for the face as it comes down. So piriformis is important. Now we're looking at the uterine influence in rotational factors. So this is looking at, the way the fibers are orientated in the uterus is that when they make a contraction, there is a spiral contraction through the uterus. So this drives the baby through this rotation. And you see we have this nice axis here where the baby is driven inferiorly, its head comes in contact with the cervix, and that causes the cervix to dilate, or efface first of all and then dilate. But we see in this picture, we can see those same contractions, but we see there is a change in axis where the cervix is posterior. It's facing much more posterior rather than inferior. So what effect might that have, do you think, during a labour?
The baby can turn, no?
Well, it can certainly affect the baby can turn, but what else would happen?
It's going to be really painful
Why?
because you're pushing against the sacrum and the coccyx.
There is that, well, yeah, that's potential, but actually think about where these contractions, so when the contractions here, the baby's head is pushed down, so those contractions are still going to push the baby's head down along this axis to here, instead of here. So what might be slower as a result? Yeah, dilation of the cervix is going to be very slow. So it's going to prolong labour, because all the pressure is going to be going here, rather than on the cervix directly, so it's an inefficient labour. So these are these uterosacral ligaments here, which are hypercontracted. So it is possible to treat these, and it actually relatively easily, internally, potentially, where you can work to balance the cervix, and you can bring it into a more anterior position. And it responds amazingly well. I mean, it's extraordinary. You just think, well, how can that be? These ligaments are really tough. And
I didn't get that.
No, you didn't. No, that's right. But you can literally feel the cervix. You can often feel the cervix is held to one side, laterally, or very posteriorly. And if you make a contact on it, you can, and you just, as you were doing an unwinding, you just allow the tissue just to follow its tension. You don't even have to put any pressure into it. It will self-correct, and it's extraordinary. And obviously, do I do this very often? Not that often, because you're not really, most women don't really, quite understandably, want to have an internal done unnecessarily, and you don't know always. But if we were there present, and this is where I think we need to talk about this issue of, there are influences we can have, but the law is very clear that we don't actually treat pregnant women. The only people who are permitted to treat pregnancy are midwives and primary care practitioners, doctors. So we are primary care practitioners, but under law we are there to give musculoskeletal support. We're not there to treat the pregnancy. We don't turn babies, we don't do deliveries, we don't improve delivery. It's very clear about what we need. We are there to support basic physiology and musculoskeletal health. So we have to be careful about the claims. And actually even the language that we use. There was a case years ago where a chap was asked to be there at the delivery, and he was talking about doing a cranial balancing technique to encourage the baby to turn. But he used the words, we could do something to turn the baby. The midwife was there. She took umbrage at that, thought that he was overstepping his boundaries. He was reported to the GIOSC. And there was a huge case, and he said, and Renzo got involved, and it was the language he used. She heard, "I'm going to turn the baby." She heard that as that's a medical procedure, which is where it's quite violent is the wrong word. It's a strong, direct technique where the baby is turned. That's what she thought he meant. He meant something very different, which is create space, and if the baby will turn, it will turn, and just to help the labour. So it was all about miscommunication and how we use and so that very clearly defines that midwives have a role, we have a role. Theirs is defined in law. They are the only ones who are permitted to work on a pregnant woman and support her in labour, whereas we are not. We can be invited to be there, but we have very clear boundaries, and we need to be very careful about the words that we use so that we don't misconstrue. And actually the patient didn't complain. The patient was really supportive. She came to the tribunal and tried to get it all, but it was because the medical professional had heard one thing and was trying to, she interpreted one thing. So it's very, very, very important that we're clear about what we mean and we don't overstate what we do. In my mind, we're simply there to try and support physiology. And I say, this may make no difference. I say that all the time. I spend most of my day saying that to my patient. This may make no difference, but I'm hoping it will help you and make you more comfortable. Yes.
What was the outcome of that case?
I can't remember. I mean, he's no longer on the register, but I don't think it was because of that necessarily. And that's about as far as I can go with that, I think. Yes. Okay. So we can see in this picture also there are these guy ropes. So if you imagine this is like a parachute or a tent, what's this ligament here? This one in the front, sorry. Sorry, I'm out of shot for those on the film.
Round.
Yes, this is the round ligament. Yes, so the round ligament, and then we have uterosacral ligaments here. So the round ligament in the non-pregnant state is here, and we're going to palpate that later. Uterosacral, you can work on that internally, but I think if we can at least get the sacrum functioning well, then you're going to have an influence on function of the uterosacral ligament, potentially, indirectly. Okay, so these are the guy ropes. So uterosacral ligament, the cardinal ligaments, which are lateral, they run out laterally to the lateral pelvis. The round ligament comes ultimately, you've got to think about, men and women are actually really very similar. And so the round ligament is really where the track, when you think of where the testes have had to descend through the abdomen. They started out as ovaries and they just end up externally. They follow the path down through the inguinal canal and externally into the scrotum. But the round ligament follows that same path. It's exactly the same structure. It's just that the testes carried on, the ovaries stopped, but the gubernaculum, which is what leads the way, And that's the sort of the preparation for the round ligament carried on. And so effectively the round ligament inserts into the labia majora, so it's on the anterior pubis. So you can palpate it there, and you can feel if that ligament is inflamed. You just rub your finger very lightly over the pubis, and you can feel it underneath your finger, and often it can be quite uncomfortable, and there are ways in which we can release that by stretching along its attachments along through the inguinal, and then from the inguinal up onto the uterus. So it is an important structure. So yes, so round ligament we'll talk about, the fallopian tubes, the broad ligament, and then the pelvic floor, the state of the pelvic floor. So those are all sort of uterine gyros, if you like. Almost there, I think. How much? So this is just looking at what, if the uterus is free, when you side bend one way, the uterus should rotate in the opposite direction. If those guy ropes are under tension, when you induce that side bending, you see the uterus comes under strain here. And this is not ideal. This is not going to help for an optimal labour because you've got tension. And you can release this with some of the techniques we will look at. And I think we're going to leave it there. So let's take a break. Sorry, we've covered a lot. I will try and finish off the theory very quickly and we're going to get into practical. Okay? Good.